Good day, everybody. How you doing, Harshad? Are you there?
Hi, good evening, good afternoon, good morning.
How you doing? That's
I'm
right.
fine. How are you?
It's evening there, right?
Yeah, there is a good evening here in Bombay.
Okay.
It's 5:30 now.
Welcome. Well,
Thank you, thank you.
you're going for perfect attendance.
Yes, I like to be.
Good.
I really enjoy and I'm really learning and participating also.
Well, it's good to see you taking advantage of it. It's here.
Yes,
Why?
I'm
Why
taking full
not? Why
advantage.
not? Why not?
Yes, yes.
Yeah. I wish I was a kid again. I tell
Well,
you, with it growing up with computers, man, oh man, what an advantage these kids
yes,
have.
yes.
These kids have, I think.
Yeah.
I don't know if they realize it, but
I finished more than 30 years in neurosurgery. I still feel I'm a kid.
yeah, well, that's a good feeling to have. I think
Yeah, I feel I don't know much. I still feel 30 years. Me and
yeah,
Atul Goyal, we are classmates,
yeah,
contemporaries.
I think most neurosurgeons feel the same.
Yeah. 30 years
They're
is over now.
constantly learning.
Yes, yes. Good, good, good.
This
Looking
is
forward to hear.
great. We get to talk to Dr. Ugur. Dr. Ugur,
Yeah,
you there? You there?
yes.
Dr. Ugur, are you there?
Yes, how are you?
Hey, how you doing? Nice to meet you.
Very well. Thank you.
Let me get off my screen there. Okay, great. You know how to use this platform. Do you have you used
I
it?
hope so. Yeah.
We want to try it, run through
Yeah,
it
let's
real quick.
do it. Yeah,
Yeah,
share screen.
Yeah,
And this is my keynote.
very good. Do you like that banner?
Yes.
Yeah, that's
And
a neurosurgeon
this
from Thailand.
video also.
Yeah.
You can see video. Okay.
Yeah. Do you need sound from the video or no?
No stuff.
Okay. Is that
So
the
it's over.
only video? Is that the only video?
No, I have some other, but it doesn't matter. One
Okay.
of them working. I have many. Yeah.
Okay, the same principle.
Stop share, huh?
Yep. There we go. Okay.
And so I am ready.
Okay. We're waiting for Juha. We're waiting for Ben. Ben, they always come at the last minute and make me nervous. Are they going to show up? No, but they always show up, or they'll let me know. It hasn't happened. Knock on wood. So are you pretty active, Dr. Ture, doing webinars? Or you just
Yes.
Oh, okay. It was new to you, right?
What?
It was new for you to learn it.
Yes, of course. Yeah, we started 1 year ago with COVID-19.
Oh, that's when you started, huh?
Yeah. I congratulate you for this organization. You are very active, really,
Well,
and helping education all over the world.
I love this platform. When I first saw it, I thought, wow, this is excellent. This is before COVID, a couple of years before.
Wow.
And then COVID came, of course, and because I used to have to convince doctors to use it. But now they know what it is. They know what it is.
We had to learn, yeah.
Yeah, it was completely different before COVID. We used a platform called Google Hangout. You probably don't even remember that.
I don't remember. Yeah.
It was not a lot harder, but it was harder to use than this. This is a lot easier. Here's you are now. You're probably old buddies.
So you are in Miami now, huh?
Yes, Miami Beach. There's Juha. There's Juha. How you doing, Juha?
Hello, John. Hello, Guru.
Hello, hello, Yuha. How are you?
Hello.
Nice
fine.
to see you.
We had some difficulties connecting, so sorry
I
to be
see.
late.
No, no. How are you doing?
It's okay. It's okay.
Very nice.
Oh.
Nice to see you again. Thank you for the invitation.
Yeah, it's great that you could come.
Thank you.
I'm very happy.
Well, when Juha asks, people answer. Thank goodness.
Dr. Najar is here also. Hello, Jalal.
How you do? How you do, Professor Torre?
Very nice. Very nice to see you.
Great to see you.
It's always great to see you. You are
I
doing
was
well?
thinking Istanbul is
Yeah.
doing good.
Yeah, very
How
good.
is our professor, Professor Yashergil?
He's doing very well.
Still
He
in
is
house
at
or
home because of
at
the
home?
COVID-19. So I didn't see him this week, but I will see him on Monday. Yeah, he got tired to stay at home, but it was good for him. But now
Yes.
he had a vaccination, so maybe he can come to us.
Yes, great news. So maybe he will be back to university in some days.
Yes,
for
yes,
visiting.
yes, yes.
This is
yes.
great. So maybe
Yeah.
we have the course this year because it was cancelled
No,
twice.
this year is not impossible. It looks like not possible.
Hmm.
This year
Unfortunately.
still we are going to in trouble with COVID-19, I think.
Mhm.
Mhm.
Great to see you.
We got 6 minutes.
Yeah.
6 minutes, yeah.
Hello, Professor.
Hello, hello.
Hello, this is
Hassan.
Dr. Rajat Parekh from Mumbai, India.
Hello.
How are you doing?
Very well. What about you?
Right. Good,
Nice.
good. Everything good. Looking forward
Thank
to
you.
Harshad is
Thank
one
you
of our
very much.
better students.
right.
Okay, we have the Japanese translator coming in now.
Hello, Professor Juha, Professor Uguture.
Hi,
My
how
name is
are
Danu
you?
from Indonesia. Hello,
Nice to
Hello,
Dr. John.
Danu.
Hello, hello.
That a
Yeah.
boy. That's how to use this platform. Introduce yourself. Meet people. That's great.
Thank you. Thank you for making it come true, Dr. John.
Yes, well, great. This is you're using it the right way.
Thank you.
Hey, you gotta join this group called doc.social. It's gonna change the web.
Mhm.
It's an excellent website because they have all the tools there when you build a website, so you don't have to build them. So we're building a community now on artificial intelligence and neurosurgery, and everyone, of course, is welcome to join. And I'm going to show you. This is my chance to screen share. You
Hello, John. Can you hear me?
Yeah.
Hi.
Let me just
Good
share
evening.
Okay, this is the doc.social. I don't own any of it or have nothing to do with it, but it's a great platform. And we created this artificial intelligence neurosurgery community, and we're going to have webcasts and that and stuff like that. But anyways, we'll talk about that later. Hey, Takashi.
Hey, good evening. Good
Hi,
evening, John.
Hello,
Good
Dr.
evening, everyone.
Good
welcome
evening.
to
Good evening.
Dr. Ture, Takashi is a Japanese translator.
Nice to meet with you.
Yeah, he's going to be
Nice to meet you,
training.
Dr. Ture.
Dr. Ture,
Hey.
Ture, for Japanese participants, I will help to translate into Japanese.
Thank you very much.
Thank you.
I want to say hello to Dr. Ture.
Hey, hello. How are you?
I am very happy to see you.
Thank you
I'm
very much.
glad.
Thank you.
I learned from you a lot.
Thank you very much.
Thank you for coming.
Welcome. Ich habe auch in Deutschland, ich bin hier in Deutschland, Herr Ture. Verstehen Sie? I want to come to Turkey and take a photo with Herr Ture and Professor Yazargil. I
Sure.
hope you will help me.
Of course. Pleasure.
I will do that.
Okay. We have 2 minutes. If you, okay. Does anybody else want to meet Dr. Ture informally and say hi? Real quick before we start. You know, Dr. Ture, this is turning out to be a networking thing. Hopefully, like after the chat, you kind of like a conference that people hang out. Do you know what I mean? Maybe not. Anyways, it's just an idea. Well, people wait after the conference to talk, you know, to meet.
I
people.
see. I see.
Hopefully, it'll happen.
I see.
That people just don't leave and stay and meet. Hopefully, if you have time. You
Yes,
don't
I have time. Yeah, I have
Yeah,
time.
Okay.
You mean to stay online? Yeah.
Yeah, but and then I go off YouTube, I go off
Yes.
Zoom, so it's just a private meeting then. So you
Yes.
can talk, you know, frankly.
So you don't have any fellows now, right now in the operation in the OR, Professor Ture?
I have
It's-
many.
You have many. How
Yeah.
in the COVID?
Yeah, but they came here and we perform tests and they stay. So yeah, I have many
Oh.
now.
So it's okay to attend some operation with you. Last month I was in Istanbul, but I
Oh,
think that
please
will be very
visit.
difficult.
Yeah. You can visit us anytime. Yeah, please.
Oh,
John,
so it's okay.
Subin
Thank
cannot
you.
log in. Can
Oh.
you send him the new?
Yeah, I sent them it yesterday. I'll send it again. Okay.
Send again.
Okay.
So we wait a little bit for Subin.
Yeah,
It's
sure.
important because he's
Sure.
translating in Chinese and there is a big audience.
Okay, no problem.
Professor Ture, can you send me your email address, please?
How can I send it?
Yeah. Your email address, because
Yeah,
I didn't find your email in internet.
I see.
Because I want to come to
DRTURE.
Turkey.
Yeah, DRTURE.
You can put it on chat, Professor. If you
Put
put
it,
on
please.
chat, it will be
It's complicated work. I don't want to play with the computer now.
Yeah, but after lecture you can change.
Yeah, after lecture, after
Yeah, yeah.
lecture.
In the
I don't
chatting.
want to play with the
You will have some
presentation.
complications.
Yeah, because I have searched that in internet. I didn't find your email on the website.
Yeah, I will tell you after the lecture.
Still waiting for Ben.
I will ask him.
I sent him 2 emails.
You have to send in WeChat, John.
Oh, I don't communicate with him on WeChat.
Oh,
Okay.
you have to change the WeChat.
Yeah, I have to change that. Can you send him the link?
Yeah.
I'll send it again in his email. That's how I usually communicate with him. Email. He's pretty responsive usually. Yeah, we got a couple minutes. Welcome everybody. We're trying to get a hold of Dr. Ben. Dr. Lanzino. Excellent, excellent. Hi, Dr. Lanzino. Whoop. He's coming in here.
Good morning.
Hey, good morning.
everybody.
Good morning, Dr.
Hello,
Lanzino.
Giuseppe. Hello, Giuseppe.
Hello.
You're welcome. We're just waiting, Dr. Lanzino, for Ben to come. This happened before, but he came.
Subin cannot join. What
Okay.
happening?
Okay, well,
We had also difficulties.
oh, okay.
Can you
So the link I gave him,
link to Subin?
Oh, this one is just for you. Oh,
yeah, I sent him the link again.
you
The link is working. The link is working.
Hmm?
It's working, yeah. It could be his connection. Okay, Dr. Goel's here.
let me try to which is
You have his WeChat?
Sorry about this, folks.
okay, so email address.
Hi, Juha.
Hey, Dr. Goel, welcome.
Welcome.
Oh, hello, Atul.
Thank
Hello,
you,
Atul.
John. Thank you. Juha, how are you, Juha? Everything okay?
Yeah, we are waiting for Subin. So he has some difficulties in connecting.
Okay. But Ugur is there?
Hello,
Ugur
Atko,
is
how are
here.
you?
How
Hi,
are you,
friend.
Ugur?
Very
Looking
well,
forward
thank
to
you.
your lecture.
Thank you very much.
Looks like you're in your limo,
Yeah.
Dr. Well.
Yeah, I'm on the way back home.
Oh, Zoom number is banned in China. Oh, this is a new development. Facebook is banned in China.
John, is it possible, John?
Yes.
Do you think it's because I had to do also some things on my computer? Is it because you send a link that goes through Facebook? Maybe that's the issue.
Oh, okay. Well, no, I'm sending him the link in his email. Okay, I'll do that right now. It's not. Oh no. Hold on. Okay, hold on. Okay, let me get him the original link. Okay, that's okay. Just give me a second.
Hello, Subin. I sent mine. Try this one in WeChat. I sent which we were successful. Try this one.
Okay. Yeah, I'm gonna send him a different link, the original link. Oh. Okay, yeah, I'm gonna send to you also. I'll send it to your.
Then in my WeChat, so I will send.
Yeah, I'll send it to your
To
WeChat.
Subin.
I'll send it. Yeah. Okay. Yeah, this will do it. Okay, that's the original link I sent you, Juha, in your WeChat.
Waiting for that. Yeah.
Yeah, that's a different link. Hopefully that'll work. Hopefully. Thanks for everyone's patience. It just gets a little tricky sometimes. I use a domain shortening platform that may have been a Facebook platform. Yeah, I think that should work because it usually works. All the other time he's joined, we haven't had this problem. But things change. But I bet you it works. Well, we take our coffee break before the conference.
Okay, I can make a short introduction. So during this time, Subin can connect. Or...
Okay. Let me start. You want me to start? Okay.
Yeah,
let me start here. Let me start. Yeah. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. The the home of Neurosurgical TV. Today we have Juha's Neurosurgical Grand Rounds, and Ben is here. He just arrived.
Okay, great.
Okay, good timing. Good timing. At any rate, we have another webcast for Juha's Neurosurgery Grand Rounds, and we welcome the Chinese audience, and we have the translator just arrived. Anyways, I'll turn it over to Juha. Welcome, Juha.
Thank you very much. I will take my few slides here. Can you see it now?
Yes. Yes.
Okay. Welcome, everybody. Especially welcome Professor Gurture from Istanbul. He's the chairman of neurosurgery at Yeditepe University, and he's one of the most important active neurosurgeons of these times in the world. How to become a good neurosurgeon? Select good heroes and mentors, and the hero of all of us is certainly Professor Gazi Yazargil, but he's also the mentor of Professor Gurture. Professor Yazargil is the neurosurgeon of the century, neurosurgeon of all the times, as we all know. So, following Professor Yazargil to Zurich and to Little Rock, Professor Gurture learned anatomy. He was in cadaveric laboratory 5 years. Everybody was saying that he was losing his time, but like Professor Yazargil is saying, he was winning that time. And this is extremely important because learning anatomy is very important for neurosurgery. I always remember my teacher in Zurich, Professor Giant Thunder in 1968. He was shouting in anatomic lectures that medical study is a lifelong study, but anatomy is even more. So we need more than a lifetime to learn the anatomy. And you have to do good surgery, you have to know the anatomy. Neurosurgery has 3 parts: operative skills by Gurture, they are extremely high, research in anatomic papers, excellent papers, and then teaching in his courses, congresses, and webinars. He's doing a lot. And like we heard, he has, even during this COVID time, fellows to follow his surgeries, and they certainly benefit a lot. I've seen Professor Gurture at Yeditepe in his courses. He's excellent neurosurgeon, good organizer. He has the best facilities, he has everything, and he's surrounded by a good supporting team, and the patients trust him, and the society is also supporting him. And because of his skills, he has constant flow of patients. What I have observed in Yeditepe by Professor Gurture is doing impressive preoperative study of every patient. That is utmost planning of the surgery, video documentation of every operation, outcome and careful follow-up can be done. So I conclude, if you want to see and learn good microneurosurgery, go to Professor Gurture in Istanbul to Yeditepe to learn. Spend some time, you will see how good microneurosurgery is done at these times. So I thank you very much, Professor Gurture. I give you the word. You will speak about management of midbrain gliomas.
Professor Ernest Niemi, Professor Su, Professor Kohn, Professor Bennett, dear great friends, colleagues, I really thank you for all this organization. And it's great honor for me to be in juha's neurosurgery ground round. And I cannot thank enough to Professor Ernest Niemi for his support and his help and his thought to me during my career. And he is one of my main mentors, like Professor Yashargil and Professor El Mefti. And I'm very happy that he's active in China and doing very well. This is a very important picture for me in Helsinki live microneurosurgery course that Professor Ernest Niemi invited me when I was very young neurosurgeon. And after that period, he is always helping and supporting me and giving me courage, giving me energy. And I hope I will fulfill his expectations and I will try to do better. My talk today about the microsurgical management of midbrain gliomas. I choose this topic because, you know, generally the talk about brainstem surgery is too much. And because every part of brainstem, midbrain, pons, and medulla oblongata is different, totally different surgical target. Their tumors or lesions are different also. Midbrain gliomas are mostly benign, pons mostly malignant, medulla oblongata mostly benign. Their histological type is different, and the growing pattern of surgery tumors are different also. So I would like to separate these brainstem regions as a surgical target because the surgical approach is also totally different. Philosophy is different. Also, I did not want to combine with the cavernomas. Cavernomas is another story. And when you compare with the gliomas, I mean, gliomas are 10 times more difficult, to be honest with you. And so I didn't want to mix with the cavernomas and also with the metastases or other tumors. So this is my experience with the midbrain gliomas and with long-term follow-up with more than 50 patients now, which is, I think, one of the largest single surgeon series, only midbrain glioma, that I would like to share with you my experience in 15 years. First of all, of course, we have to thank our mentors. The Dr. Poole is I think, the first neurosurgeon that he performed surgery in brainstem glioma in 1968. And then, of course, Hoffman, Epstein, and Bricolo. Especially, we have to mention with their experience with the brainstem gliomas. And, of course, Professor Yashargil. Professor Yashargil published his series in very late, but he started in 1970s, the brainstem gliomas, actually, but he published very late. This is the reason he is in the last in the list. But what I learned from all brainstem surgery, he is my main teacher. You know, brainstem surgery is the series of brainstem surgery is very limited. This is one of the reasons is in many departments, brainstem surgery is not well established because these are rare tumors. In many neurosurgeons during the residency period, maybe they can see 1 or 2 cases in the department. And then to start brainstem surgery is difficult because first of all, you have to see mentor, you have to see good surgery, you have to see other people also. So I was lucky enough that I start to learn brainstem surgery. I start to observe brainstem surgery when I was 2nd year of residence. And then, to be honest with you, I started brainstem surgery when I was 44. I waited until 44. There are many reasons that I would like to share with you. As you know, that midbrain is the or mesencephalon, most rostral portion of the brainstem, and located between the pons and the encephalon. And there are several nuclei and major white matter tracts connecting the brain with the periphery. And when we look at the anatomy books, it looks like it is impossible to touch. First of all, we have to learn the midbrain anatomy. I had a difficulty for this because, you know, we learn brain anatomy in the medical school this way. In axial section, we have supratentorial anatomy. We have, for example, axial section through the insula. This is anterior, this is posterior. We have thalamus, putamen, cauda ethnicus. At least we have this orientation. And this is same in the MRI. The anterior is anterior, posterior is posterior. But it is interesting. In any neuroanatomy book, when you look the brainstem anatomy, it's upside down. This is posterior, this is anterior. This is totally against our anatomic orientation and also MRI picture. It's totally, this is colliculus, this is crus cerebri, it's upside down. So at least I cannot learn this anatomy this way. So I had to turn it. Now is the superior colliculus, is anterior is here, but I cannot read the picture. So I sit down and change in the Photoshop, and now I study this anatomy this way. And then I can imagine this structure. Now that I can put the MRI and I can put the anatomy and I put the also anatomy specimen and I can learn. This is my way that I strongly recommend. In any book, it is upside down. This is, I think, just tradition in anatomist and nobody changed it. Another problem is the MRI. In neuroradiology, they look from below, but in our surgery, we look, except transfemoidal, we look from above, and MRI, the anatomy picture and everything is wrong. They said that this is left-sided midbrain lesion. No, now this is left-sided midbrain lesion. So I changed all of my pictures, left is left. So I learned anatomy and then radiology and surgical picture and everything. It's in my mind because it's very small region. So I have to keep the picture of this structure in my surgery always. So this is two tricks. That this trick is I learned from Professor Yaşargil, the turn the MRI, and now I have orientation this way. And then I studied in the anatomy lab, the deep structures, midbrain, brainstem, and everything. So this is medial lemniscus. This is 20 years ago I did. This was one of the first picture of medial lemniscus. I never seen picture of medial lemniscus. I saw the drawings, but I had to touch them. And I can imagine now. And then corticospinal tracts. And I found that these midbrain tracts going back down to the pons, and they have 4, 5, 6 bundles. And then they came together in the medulla oblongata. So I spend a lot of time for this. And this cerebellar peduncles, part of brainstem, superior cerebellar peduncle, inferior cerebellar peduncle, middle cerebellar peduncle, and their relation with the cerebellum and the thalamus and all of them. And also, I use fiber tractography routinely for any brainstem surgery, before surgery and 3 months after surgery. I check 5 main tracts. I hope in the future I can do more, but the 5 main tracts give me idea for surgical plan. medial lemniscus and corticospinal tract. We study before surgery and 3 months after surgery, and cerebellar peduncles, superior, middle, and inferior. These 5 main tracts, before surgery and 3 months after surgery, I routinely perform to plan my surgery before surgery and to see quality of my surgery 3 months after MRI, after my surgery. Of course, neuromonitoring is very important in brainstem surgery, especially the medulla oblongata surgery. Lower cranial nerves are most critical issue, and neuromonitoring and brainstem mapping is crucial in brainstem surgery. I started 2006 to brainstem surgery, and now I have 260 more cases, and 65 of them are midbrain, and among 65, I have more than 50 glioma. So my talk belongs to these 50 midbrain glioma cases. The story of my talk is the structure of my talk is how I decide surgery and which approach I perform, because the correct indication and the surgical approach is the more than half of the surgery. So I perform 7, imagine, very small structure, 7 different approaches. And also 8-1 is the endoscopic third ventriculostomy in some selected cases I will show you. But the microsurgically, I perform 7 approaches. This is 4-year-old boy, 2 weeks history of left-sided slight hemiparesis. When we look at this MRI, it looks like this is right side, so left is left, please. It looks like right-sided crus cerebri tumor. It looks like right-sided crus cerebri glioma. Even some people call this thalamo-peduncular glioma. When you we perform the tractography, look at this. The sensory and motor fibers move medially and posteriorly. And the anterior part, just, the some part passing through the crus cerebri, and there is some like exophytic part here. So my surgery should be anterior. So what is anterior? Is transsylvian. So go to transsylvian, but I remove the orbital rim also, which I learned from Professor El Mefti, because when you remove the orbital rim, you can get the brain base, you can get better angle to brain base, not only skull base. Base of brain is also, you can get it. So I performed transsylvian approach, and this was after resection. And look at the picture. It looks like a crus cerebri tumor, but it turned out to be tegmentum tumor. So the tegmentum tumor originates from tegmentum and separates fibers of the crus cerebri and came to the surface. So this also shows that patient was not hemiplegic before surgery. He had just slight hemiparesis. So this is important point for me, that I do not have crus cerebri glioma in my series, and I do not have thalamo-peduncular glioma. This is interesting point. And this is pilostic astrocytoma. This is, I operated 14 years ago, and sensory and motor fibers are almost intact after surgery. And this is early postoperative, 2006. And now he is totally big boy and no recurrence, nothing, and no deficit. When I see this MRI, okay, this is crus cerebri tumor. This is again 4-year-old boy, again interesting. And he had a left-sided hemiparesis, progressive. And when I looked this, I said, okay, this is crus cerebri tumor or thalamo-peduncular tumor or whatever. But the same story. Again, sensory and motor fibers move laterally and posteriorly, so I can get from anterior. And this is after surgery. And it was tegmentum tumor again. And this tumor did not invade the thalamus, did not invade the pons. I've noticed this. The midbrain gliomas do not invade the thalamus. They don't go to pons. I have some cases that tumor is everywhere. Multifocal GBM. This is another story. It's very rare, and it is not surgical candidate for me. Yeah, I do not do surgery for them. But the most of the cases, tumor has some philosophy to stay. And this is again also tegmentum glioma, not crus cerebri or thalamopeduncular glioma, and it was pilostygastrocytoma. He had a third nerve paralysis before surgery, and it's okay after surgery. This is two cases that I go through the crus cerebri. So people are talking about the safe entry zone of brainstem. There is no safe entry zone in brainstem, but tumor or lesion can give us some entry points. In these two cases, it was tegmentum gliomas, but they came to surface in the crus. So I go through the crus. I go through the tumor. So this is an important point. We have to follow the tumors or lesion, what they are offering us. We have to look at this. I have two cases with Transylvanian approach. Another approach is this one. This is typical aqueduct. This is another entity. There is diffuse periaqueductal gliomas, which is not candidate for microsurgical removal for me today. But there are cases that very well circumscribed, very well located in the aqueduct, and they result with the acute hydrocephalus. When I look this picture, of course, this is classically you can perform third ventriculostomy, but it looks like more difficult for me to third ventriculostomy. He has a hydrocephalus, so why not to go from here transcallosal and to remove the tumor? So this is my first case. I described the patient. What is my plan? And this is my plan. It is extreme anterior. It's like transcallosal, but I go through the genu and body, between genu and body, not in mode. So we simulate this surgery. If we can get the correct angle and with the enlarged foramen Monro, because if the patient doesn't have hydrocephalus, I cannot perform this surgery. But when the hydrocephalus exists, I can go through the open foramen Monro. And this is surgical approach, right-sided craniotomy, and this is corpus callosum. So where I have to put my incision. This is my best technique is the cotonoid. Some people is upset. I have navigation, but I mean, this looks more comfortable to me. You know, just to show here again, to put a cotton and to decide the exact surgical incision. You see, this is genu, body, and the cotton. If I can get this angle, I can get the tumor. And small incision is enough to go there. Even I do not need to do it. I don't do this. You do not need to coagulate. Just separate the callosal fibers. And between, I always do between two pericallosal arteries. And then if you can get the correct angle, you are there. If you don't get the correct angle, close. You can do nothing. And just to check with the endoscope, releasing CSF. And you see, this is aqueduct and this is tumor. Very long bipolar, very long suction, but it's possible. This is microneurosurgery. This is endoscopic view. This is right side foramen of Monro, anterior septal vein, and posterior commissure. And you see, this is well circumscribed aqueduct tumor. And they attach to aqueduct in one side. And just go there. With in endoscope, maybe you can suck some of them, but these are not, at least I have 6 cases, they were not suckable tumors. So I think it is less invasive than endoscopic approach. This is my opinion. Sorry, maybe some people is upset, but because with endoscope, you have to pass through the whole cortex, and I just do small callosal incision. And just go there anyway. And in 3 minutes, you have nothing to change. You cannot change the instruments. You know, you have working in very small angle, even to see is difficult 3D. And just coagulate the attachment. I know it's difficult to see, but it's worth it. It is pilocytic astrocytoma. And again, I am checking with the endoscope that I removed all of them. And I have to see the CSF is coming from 4th ventricle. You see the CSF is coming and no residual tumor in the aqueduct. And this was result. You see, this was the angle to go and to remove this without touching choroidal fissure or without cutting fornix or whatever. And this is small incision. And some people that I am exaggerating with this incision, but I like to show you the all pictures. Look at here. I am starting. So because when you separate the callosal fibers, some of them come back. Anyway, I am maybe too much, but you can do bigger incision. It's not a point, but it's possible. That's the point. And we published this technique. And after this case, I performed this approach again. This is another case, again, aqueduct tumor, hydrocephalus, and that's it. Go through this way. Another case, again, aqueduct tumor, hydrocephalus, large foramen of Monro, but in this case, there is interthalamic adhesion also. This is more difficult because I don't want to cut. Even you can cut it, but don't try. And then this is after resection. It was, and it's interesting, all of them were low-grade tumor. So the third approach, this is tectal tumor, large tectal tumor, and with hydrocephalus. So when I see tectal tumors, I have 2 approaches. One is the supracerebellar, another one is the posterior interhemispheric. Yeah. Another one is the posterior interhemispheric approach. If the tumor is not going below the splenium and not going up, I prefer posterior interhemispheric approach. Sorry. The superior cerebellar peduncle is very critical issue in this case. You see that they are, you cannot, but they are separated by the tumor. So I perform an lateral position. In these days, because of the intraoperative MRI, I perform in prone oblique position. And this is after resection. And you see, this is good angle to go to remove this tumor and release the hydrocephalus. And in some cases, in early postoperative period, the patient may have upward gaze palsy, but they all recover. This is 3 months later. Another case, this is typical tectal tumor. You know, there is also issue that diffuse tectal gliomas. most of them, it looks like diffuse, but most of them are not diffuse. Most of them arise from one colliculus. So this looks like diffuse tectal glioma, but when you pay attention, this is left-sided colliculus tumor. And the same approach, superior cerebellar peduncle push anteriorly. And I never seen destroyed superior cerebellar peduncle in the midbrain gliomas. The superior cerebellar peduncle is always intact. You see, after surgery, it was superior left-sided colliculus. The other colliculus are intact. So before surgery, it was all tectum. But you see, after removal, I found that they originate from one colliculus. And superior cerebellar peduncle is in normal position now. Pilostic astrocytoma. Again, it looks like everywhere, all tectum. This is intraoperative MRI. 2.5 years ago, we started to use intraoperative MRI, and I like it. It's nice, but we should not exaggerate because we are doing the surgery. It doesn't change my quality of surgery, but it's nice to have that if you left some stupid piece, you have a chance to remove. But some people are comparing with intraoperative MRI and intraoperative ultrasound, which is not fair. They are different. Intraoperative MRI is another story. Intraoperative ultrasound is another story. It looks like one of them is car, one of them is airplane. They both can take us from somewhere to somewhere, but they are different. And if you ask me which one is more important, of course, ultrasound is more important. And if you have to choose one of them, my first choice is intraoperative ultrasound, which is most important for me. But it's nice to have both. And this is after resection. Peduncles in pilostic astrocytoma. Another case, it looks like every glioma. And you see, again, this is right-sided superior colliculus tumor. The left superior and inferior right is intact also after surgery. Pilostic astrocytoma. This looks like extreme. It looks like destroy everything. But she had just slight hemiparesis and the third nerve palsy. And it looks like all midbrain is tumor. This is tegmentum tumor. And normally, tegmentum tumor, I perform from lateral, but if you look at this, it's almost in the surface here. So if I come from here, I can get everything in one direction. So if you can look with the FLAIR images, you can see that thalamus is intact and pons is intact. They can push down to pons or they can push up to thalamus, but they don't invade. And sensory and motor fibers and superior cerebellar peduncle are intact. They push by the tumor somewhere. And this is after resection. And you can see that it is small corner in the tegmentum was the origin of the tumor. And it was pilostic astrocytoma again. And this is sensory and motor fibers and superior cerebellar peduncle after surgery. And her third nerve palsy is almost recovered. She has some dilatation, but the pitosis is gone. It was a little luck. So I was not expecting this, but I'm very happy that it's done. And again, it looks like tectum everywhere is tumor. This is after resection. Again, this is left-sided superior colliculus. Now, this is another story. This is again tegmentum tumor. I learned that tegmentum tumor can separate the crus, but in this case, the tumor came in the surface here, you see, and it go up and down, but it's just pushed down and up. In this situation, you see the sensory and motor fibers also intact, but pushed. You see the lateral is totally free. So in this case, my approach is from lateral, and just when the tumor came in the surface, and mostly the lateral mesencephalic sulcus. Lateral mesencephalic sulcus, the tumor tried to come out, tegmental tumors. And paramedian supracerebellar transtentorial approach is my choice for such a tegmentum gliomas. And I prefer in semi-sitting position. But in these days now, the intraoperative MRI, I perform it in prone oblique position. But this is my choice, first choice in semi-sitting position, and release CSF from cisterna magna, and the cerebellum went down, and you can go directly to tumor. And there is no time for this surgery, but I like to show another case. This is my approach. This is paramedian supracerebellar transtentorial approach, pilostic astrocytoma. Very similar case, again, tegmentum glioma, and lateral is almost free, right-sided, and its tumor goes up and down. This is excellent case for paramedian supracerebellar approach, is because lateral is totally free. And the superior cerebellar peduncle push backward also. Again, this way. I like to mention one issue about this. You know, many people go through the subtemporal approach in this region, which I respect their experience. But, you know, this part of the tegmental part of midbrain, you can go through the subtemporal approach. But whatever you drill the bone, you have to retract the temporal lobe. And then also there are temporal basal veins here. And if you damage them, you will have an infarction. Maybe clinically not, but in MRI you can see. For this reason, I never perform subtemporal approach. When you perform supracerebellar, when you release CSF, even in prone oblique or lateral position, the cerebellum went down without retraction. So I prefer to go supracerebellar. Of course, in both approach, you have to cut the tentorium. Subtemporal transtentorial or supracerebellar transtentorial. You can get the same area, but I prefer supracerebellar approach. And in this case, the patient had a cardiac septal defect. For this reason, I perform it in lateral oblique position. You see, in 2-3 minutes, you are there. You can see that this is tentorium, right side. This is fourth nerve. We have to be careful. There are branches from superior cerebellar artery to tentorium. And you have to separate the fourth nerve and then just to cut the tentorium perpendicular to hiatus. And in 5 minutes, you can front with the tumor. And in this case, you see tumor is almost in the surface. So, but look at this, fibers are going this direction. So you have to cut open midbrain this way, parallel to fibers. And the pilostic astrocytoma is coming out. So this is safe entry zone to me. Tumor is the safe entry zone, or lesion is the, or lesion open the some entrance. And then I check with the endoscope, which is very crucial in every surgery. I use it, I love it, but I don't perform pure endoscopic. You see, there is residual tumor in the upper part, and there is residual tumor in the lower part. So, which I could not see with the microscope. So you see, there is residual tumor there, and there is residual tumor in the upper part. And I use CUSA to remove the residual tumor. with the help of endoscope. And only endoscope, I cannot manipulate very well. I turn again the microscope and remove the residual tumor. And now the inferior part. I know that there is tumor. So we have to use the low power of CUSA, and we have to find the border between tumor and the normal tissue. So now I am checking, it looks okay to me. And I'm checking with the lower 30 degree endoscope, lower part, and it looks like there is no residual tumor. And I'm checking, I am crazy with these tentorial veins. I try to preserve them. Maybe nothing may happen, but now I like to preserve them. And I'm also checking with the subcortical stimulation. It's nice to have it. It's nice to prove it, but I don't trust it. If I don't have a response, don't worry. You know, this technical issue is always with us, but this is something that we have to use it. This is after resection, that tegmentum glioma. And this is post-operative tractography. And superior cerebellar peduncle is intact also, pilostygastrosarcoma. This is similar case again. This is left-sided tegmentum glioma. Again, lateral approach this way. And intact tractography, pilostygastrosarcoma. Again, it looks like this is another case, colliculus, but a little more lateral. So I perform this because also that I can get there with paramedian approach because of the intraoperative MRI. So this is intraoperative MRI. I use paramedian approach for this. And this is after resection. This is intraoperative MRI. And this is 3 months after surgery. So I use paramedian approach for this case, also tectal glioma, because of the intraoperative MRI. Now, this is typical tectal glioma. This is another issue, another approach, which is supracerebellar. To be honest with you, today, I can use also this approach for this. You can, there are some tectal cases, you can use both approaches. And there are some cases I prefer posterior intrahemispheric. There are some cases I prefer supracerebellar. In this case, you can do both. And I perform, this is cerebellar peduncles. You see, it's pushed laterally. I perform perimedial supracerebellar infratentorial. I never perform midline. I perform inside. To preserve, first of all, because all the veins are in the midline and I preserve them. Another issue is, especially tentorial angle, especially in Turkish patients, because of the steep angle, I prefer to go from lateral, which I learned from Professor Yaşargil. So any colliculus, I go perimedian supracerebellar infratentorial approach. The tumor is just front of you without touching anything in semi-sitting position. And this is after resection. And again, it is, you see, it is left-sided inferior tumor. This is cerebellar peduncles. Another case, this patient had a just tremor, nothing wrong. Okay, we can wait a little. You see, they are growing. So, and then this is same approach. I remove it with the tectal glioma, then left-sided colliculus tumor, inferior colliculus tumor, using perimedian supracerebellar approach. This is more complicated. 3 times operated in another institution, right-sided Turner palsy and left-sided hemiparesis. It looks like all midbrain, but when you pay attention, we know that there is no crus glioma. This is tegmentum glioma, extend posterior to the almost surface, and then goes anterior to the crus cerebri. But how can I remove this? Which approach I can? And it's also going down almost to the foramen magendi, cystic part. But still, thalamus is intact, pons is intact. It just pushed by the tumor. So this was very tricky case that how can I approach? So tractography gave me some idea. You see, I cannot go through lateral. I maybe go anterior, but I cannot go down. I cannot reach down. So maybe perimedian. You see, there are midbrain covering the lateral and posterior part. So I perform contralateral perimedian supracerebellar, go through this way. This is my only case that I perform contralateral, and the tumor came to the surface here. So I go inside of the midbrain, and this is basilar tip from posterior. So basilar tip is pulsating. So I left a little piece of tumor over the basilar tip because it was firm tumor. I had to increase the power of CUSA, and then you can damage the basilar. So I left a little piece over the basilar tip. In this case, contralateral perimedian supracerebellar. And you see, I go through here, and I left a little piece in this corner. But you see, the tumor is tegmentum tumor, not thalamus, not pons. And it is nice to see that the sensory and motor fibers are almost intact. And she recovered, and then her Turner palsy also recovered. And no, interesting. I have some case that pilocytic astrocytoma, 1 year later, I have recurrence, and when I remove totally. But I have some cases that pilocytic astrocytoma, I left a little piece, and it stayed stable without radiation or gamma knife. Interesting. So this is my last approach. Same aqueduct tumor, well circumscribed, but in the lower aqueduct. So I cannot come from here to here. So just go uvulotonsillary. I have 2 cases like this. And in semi-sitting position between uvula and tonsil, which I learned from Professor Yaşargil. He used this approach, started to use 50 years ago. And just separate uvula and tonsil, go up. And remove the aqueduct tumor. It was pilocytic astrocytoma again, to go this way. And this is another entity. And then last samples are diffuse periaqueductal tumors. This is another entity. This is not colliculus tumor because the 360 degree surrounding the aqueduct, and they are low-grade gliomas, fortunately, and they grow very slowly. And I perform third ventriculostomy, endoscopic third ventriculostomy. I have 3 cases like this, and they stay stable. So, but if they grow, I may remove subtotally, but I'm waiting for them. This is again another case. Colliculus tumor, nice case, hydrocephalus. I removed very well. And, you know, sometimes I feel that I did good surgery. You know, when I feel something like that, I have a problem. She did not wake up. This is my only major complication in my series. And I didn't have MRI that time, intraoperative MRI. I performed CT scan immediately. Nothing wrong. And we hope that next day she can wake up, and next day and whatever, and maybe anesthesia. Anyway, she did not wake up. And we performed MRI, and she had a bilateral anterior cerebral artery infarction. I couldn't understand how this happened. There is only possibility. Azygos pericallosal artery, if some emboli happen to azygos, but we perform angiography also, no azygos. Anyway, she did not wake up, And still, I did not learn anything from this complication. And I am very sorry that she passed away almost 1.5, 2 years later because of the recurrence. It was a high-grade diffuse midline glioma, and she passed away 1.5 years later. And this is really terrible experience for me. Another experience that I like to share with you. This is again tectal glioma. I told you in tectal glioma in these days, if possible, I prefer posterior approach because of intraoperative MRI. So if the course it's not suitable, but this case looks suitable. You can use posterior interhemispheric transtentorial, or you can use perimedian supracerebellar. This case is suitable to my choice is posterior interhemispheric because intraoperative MRI. And I went there and I couldn't remove because this tumor was totally adherent to galenic venous system, and I could not manipulate to use CUSA to remove it. It was very firm, and I stopped surgery. I have intraoperative MRI, I have everything, whatever. Wrong approach, I stop. And then I mentioned the patient's family, and for 5 days later, I performed supracerebellar, perimedian supracerebellar approach to remove the residual tumor. So these two approaches, they are different approaches. And there are some cases that you can use both, but even in this case, I was not able to remove with this lesion using posterior interhemispheric, and I used with perimedian supracerebellar, and it was pilocytic astrocytoma. And then the last sample I like to show you, this is a 3-year-old girl, and just incidental finding. She is totally intact. And left-sided tegmental glioma. This is typical tegmental glioma with edema. And very nice case. It's almost in the surface in the lateral mesencephalic sulcus. Excellent case for surgery. And I explained this to family, and they start to cry. And I understand that I cannot operate now. When I find some incidental lesions, I don't jump them immediately. I gave them a little time to recover and a little also time to accept this. Because they are in shock. So I said, okay, let's wait 3 months. And then we wait 3 months, nothing changed. And she is still intact, running around. Anyway, we wait. 5 years later, 10 years later, it's gone. And she is totally intact. And I was almost going to operate her, imagine. And I don't know what was it. And I have maybe 20 very detailed MRI. If somebody wants, I can send. Some neuroradiologists maybe give idea what was it. But at the end, you see, I was going to operate her. This is also interesting that I like to share with you. So I have now more than 55, but this is my statistics, 50 midbrain glioma, and mostly pediatric cases. I have no crus cerebri glioma, no thalamopeduncular glioma. Interesting. Bricolo also doesn't have it. He did not discuss this, but when you look his series, he has tegmentum tumor, he has tectum tumor, he has no crus cerebri glioma. And also Yashargil, in his series, I talked with Yashargil. He just think it, and then he said, yes, he doesn't have also crus cerebri. These tumors has some size that is choosing, and nor also red nucleus glioma. Red nucleus is always intact before surgery and after surgery. It's interesting. And tegmentum and tectum, and also I have 9 aqueduct tumors. And So I performed 7 approaches with endoscopic third ventriculostomy 6, and mostly posterior interventional transtentorial, especially with the MRI. This is generally my first choice. And most of them low grade. I have 6 high grade gliomas, and glioblastoma or diffuse midline glioma. And macroscopic total means more than 99%. Near total means 95 to 99%. And subtotal less than 95. And these are my results with the glioma. And no perioperative mortality. One patient, we had a major surgical mortality, which I mentioned you, tectal glioma. And 2 patients slightly worse 3 months following surgery. And the others are same or better than preoperative period 3 months after surgery. And 3 patients died due to recurrent tumor, high-grade gliomas. And I have some cases that I had to do second or third operations due to recurrence or hydrocephalus. In conclusion, I like to show these slides always. You know, these are the new tools that we have now in modern neurosurgical times. And I love all of them. I have all of them. But none of them is controlling totally my surgery. I need more. I need to put together all this information and then put together with my understanding of surgical neuroanatomy. It is important. It's not enough. It is important, but not enough. It is just starting point. I spent 5 years in lab. I am very happy. I wish I could do more, but you know, life is so short for neurosurgery. So I have to perform neurosurgery. Otherwise, I really, especially in these days, I sit down 1 year more to study lab, but it's not possible now because of the patient flow doesn't give me this chance. Anyway, and then surgical indication is important. Surgical indication depends on the surgeon. I have some cases that today I cannot operate. I'm not telling this is inoperable. I am telling I cannot operate. Someone else may operate. My surgical indications belongs to my environment, my technique, my equipment, my experience, my knowledge. So I have to be careful about it. Of course, my indication 10 years ago different than today. I have now more courage because of this experience. But we have to be careful. And then, of course, correct surgical approach. You know, this is the main key, to choose which one is the best. Not which one you know better. No, we have to know everything. We have to know every approach. If we are a neurosurgeon, whatever this head, we have to go anywhere. Not, oh, I am not skull-based surgeon, I don't do. No, this is not possible. We are neurosurgeon. We have to drill all cranium. We have to go everywhere in the cranium. And then, of course, microsurgical technique is key. So all of them are important. This is the key. And of course, this is not my work alone. I have a great team, and I have very lucky neurosurgeon. I am that Professor Yaşargil is with us and always controlling what I am doing, and also my patients. And I'm very happy to work. Of course, not easy to operate in front of him, but I passed this examination in short time. Now I am more comfortable. And when he is in the operating room, I have more courage. And I really thanks to him for what he taught me in many years. And we were planning to do meeting in June 2020 in Istanbul, future of microneurosurgery and semi-sitting position in neurosurgery. But because of the COVID-19, it was not possible. It looks like this year is not possible, but June 2022, we hope we can live in normal world. And after COVID-19, I look forward to see you in Istanbul. Thank you for your attention. Shishi.
Okay, thank you very much. Juha?
Thank you very much for this amazing lecture, wonderful series, wonderful microsurgical skills. So this is a level of neurosurgery, extremely high level of neurosurgery. You seem to go very safely to multiple lesions. When looking at them, you are all the time excited and afraid what will happen. Wonderful work. So I give the word to the panelists.
Thank you very much, Juha. Thank you.
Yeah, it's great work. Yeah.
Questions or comments from the panelists?
Hey, Ugur, congratulations. Great lecture. Now, several times you said because of the intraoperative MRIs, you are going more and more toward the posterior interhemispheric approach, but you have been proposing and shown us great examples of the supracerebellar transtentorial approach several times. But also I have observed, I've had the same experience that you are having. Lately, I've been doing a few cases through a posterior interhemispheric transtentorial approach. And I like to hear your honest appraisal of the differences. My impression is that because you are working with your hands down, while with the superior cerebellar, supracerebellar, you're working with your hands up or at the most right in front of you. It looks like the pathology, it's a little bit more, you get closer to the pathology, you have a little bit more room. And the other issue is that, yes, sometimes the veins can be on the way, but you have a beautiful superolateral view of the veins, and you can work in between or above or below. So yes, it's an issue, but with microneurosurgery, I like to hear your perspective between the two approaches, the supracerebellar infratentorial or the posterior interhemispheric approach. In those cases, as you said, many cases you can really go either way.
Yeah, I love supracerebellar approach. This is, in my opinion, more anatomy is in front of you. You have more space, and you can manipulate. You can use both hands, and you have more space to work. I mean, my first choice is supracerebellar. There is no doubt, especially for pineal tumors, tectal tumors. But that's the point. If it's glioma, if it's cavernoma, no doubt. In cavernoma, I prefer supracerebellar. But in glioma, you know, to have intraoperative MRI looks a little luxury. But you know, I prefer if it's, I am sure I prefer again supracerebellar. But if I can do both, I prefer posterior interhemispheric because of intraoperative MRI. Posterior interhemispheric is not like a supracerebellar. Posterior interhemispheric, you don't damage the internal occipital vein. I do not retract the cuneus. I do not touch the visual field. But still, postoperatively, ask the patient. They have some visual something. They are never happy. You know, if you check with the visual field, it's intact, but they are not happy. You know, this is not a very safe approach, in my opinion. So we have to have balance. But I agree with you. My first choice is the supracerebellar. But if it's glioma, and if I want to be sure that I have to remove, I use intraoperative MRI. But maybe in a little more experience, I will turn more supracerebellar, to be honest with you.
No, I agree with you that one of the issues I've learned with the posterior interhemispheric approach is that I think it's more because of the shift of the brain. There is a significant shift that, yes, allows you to have a nice room to work, but post-operatively, I've also been surprised by the amount of temporary
Temporary visual
dysfunction. Yeah, and
Exactly.
if you go on the
Exactly.
contralateral hemisphere, I've had the patients waking up confused. You do the MRI, flare, everything looks good, and usually they recover. But I agree with you, it's the brain shift somehow, shifting the mesial portion of the hemisphere that does create temporary deficits often.
Ugur, can I make a comment? You see, supracerebellar approach is a beautiful approach, as Ugur mentions. It is not only an approach for midbrain tumors, it is also an approach for thalamic tumors. It is also an approach for even some craniopharyngiomas in the suprasellar area, behind the pituitary stalk or lateral to the pituitary stalk. It is, as you know, some tumors like I have seen Ugur doing amygdala hippocampectomy from supracerebellar route. There are several tumors in, like epidermoid tumors, going in the middle fossa. So supracerebellar approach midline and supracerebellar approach lateral are absolutely beautiful approaches. Now, you know what, Ugur, you were mentioning about sitting position. My feeling is these approaches are extremely difficult in lateral position or, sitting position. These approaches become much more easier. What is your impression about?
Exactly. I totally agree. Yeah, supracerebellar means semi-sitting position. This is my first choice. If the patient has cardiac septal defect, we perform preoperative transesophageal Doppler, and in the surgery also we perform. If the patient have cardiac septal defect, I perform in lateral, but lateral is not comfortable. Supracerebellar means semi-sitting position best. This is my
So
experience.
sitting position is a great position.
Exactly.
There is no question about it. And sitting position has great permutation and combination possible. Even now, supracerebellar approach I have described actually for the first time in literature for petroclival meningiomas. Supracerebellar, sitting position. You, as you mentioned, you normally don't talk of time that I reach in 5 minutes or 10 minutes. This is the first time today I have seen you talking about in 5 minutes I have reached the midbrain. In petroclival meningioma, supracerebellar, posteriorly pointing in the posterior cranial fossa, you reach the tumor in 5 minutes or 10 minutes. And then according to the consistency of the tumor, according to the vascularity of the tumor, you remove the tumor and you get more and more and more exposure. And you remove the tumor in quick time. And then you can go in the cavernous sinus, you cut the tentorium, go in the middle cranial fossa. I think, you know what, supracerebellar approach is absolutely a great surgical avenue. And unfortunately, many people in the world I have seen, even Juha was saying when, in China, not many people are using sitting position. In US, I think very, very few people are using sitting position. What do you say, Juha, about sitting position? What is your take on sitting position?
I love sitting position. It is wonderful, wonderful position. So it is wonderful to go supracerebellar. So it is, the nature has made the route. And it is wonderful, wonderful to do surgery. So I think we are doing here in my center, we are doing now sitting position. So it took some time to get the anesthetist and team to adapt, but now we are doing well.
Another very important,
next year,
another very important lesson that Ugur is giving to all the young neurosurgeons of the world is to understand the anatomy of fiber tracts, how the fiber tracts are displaced, how the fiber tracts are involved, and according to the displacement of the fiber tracts, you design your surgical strategy. This fiber tract anatomy and understanding is another very important message that Ugur is giving to all the young neurosurgeons. So it is time for everyone to go in the lab to understand the fibers, not only of the brainstem, of the of the limbic system, of the various fiber tracts in the brain, how the fiber tracts are displaced in the motor strip area, in the insular area, how are the fiber tracts displaced. I think these are also new. Of course, Yasser Gil has been talking for a long time and he has been giving lessons, and Ugur himself has taught the world where the fibers are going here and there. I think this is a new generation neurosurgery where fiber tract anatomy is very important for everybody to understand, learn, and design your surgical strategy according to the fiber tract displacement.
Thank you very much. Thank you for your comment, Atul. And I would like to repeat again that next year we are going to have a meeting in semi-sitting position. You all invited, as you know, Ernest Niemi and you are the most experienced neurosurgeon. I like to mention one thing that, some people had some problem maybe in the past and they abandoned this approach in the United States. Okay, maybe something happened in the past, but now the neuroanesthesiology is in another level and the technology is another level. We have now transesophageal Doppler, and we should not abandon this approach because in suitable cases, it's best approach. For me, to large acoustic schwannoma, I cannot operate in another position. Semi-sitting position is only position for me. I tried to use all of the position for large acoustics, but semi-sitting is the only for me. So we have to revitalize this semi-sitting position in our meeting. Cushing started to use transfemoidal approach 100 years ago, and then there were no microscope, no light, no equipment, and he had bad results, and he stopped. He said that he stopped transfemoidal approach, and then it started again after microsurgery with Hardy. So now everyone is using transfemoidal for many things. So something maybe not ready. Some technique is not ready for technology at that time, like a semi-sitting position. Some people had a bad experience, but they should check the heart of the patient. They should use the transesophageal Doppler or something. So anesthesiology now is in different level, and we have to use semi-sitting position for correct cases.
Okay, any more comments? Go ahead.
I think there were some comments or questions in the chat box. Can you read them, John?
Okay, let's see here. Let me see. Just give me a second. Okay.
The question is, John, for you, I will read.
Go ahead.
One question is written, what is the long-term outcome of high-grade gliomas? Do you give radiation? And I will add to this question, for gliomas, midbrain gliomas, sometimes they are high and sometimes they are low, but sometimes they are, here and there. Not high, some areas are high and a little bit here and there. What is your strategy of radiation treatment for these cases?
So I have 6 cases high-grade tumors, and they all received radiation and chemotherapy, high-grade tumors. They all received chemotherapy and radiation. 3 of them died during this follow-up period. 3 of them still survive. If there is recurrence, I reoperate them also, if possible. If it's still local recurrence, I reoperate them. I am preparing the paper now, the final, the all detailed results, but I have 6 cases high-grade glioma in midbrain.
Another question on the chat box, Ugur, for you is, and also I will like to ask you this question, which is very important question. Midbrain is located at the level of tentorium, right? Midbrain is or below the tentorium. Now the question asked by Dr. Raj is, when is posterior interhemispheric approach you find it suitable? Now, I will ask you this question is, yeah, please answer this question. When do you think posterior interhemispheric approach is a good approach for these tumors?
Posterior interhemispheric approach for tectal tumors.
Yes.
Tectal tumors, if it's inferior colliculus tumor, if the tumor is more inferior and more midline, I prefer posterior interhemispheric. If the superior colliculus tumor also extending upward underneath the splenium, and or if it goes more lateral, I go supracerebellar.
Supracerebellar and posterior
In
interhemispheric.
both approaches, I cut the tentorium.
Okay, another question which I would like to ask you is, you see, I saw your, dissection and beautiful dissection, no question, one of the finest microneurosurgeon of all times. But you know what, when you were operating inside the midbrain, I saw you having bipolar. And you were using bipolar, and even in the list of equipment you mentioned about bipolar. How much bipolar you use in the midbrain gliomas?
I am sorry, I couldn't hear you. I couldn't hear your last sentence.
Yeah, I am asking you.
Yeah, bipolar, you are talking bipolar, yeah.
Yes, I am talking bipolar, and you were holding the bipolar in your right hand in your dissection, during the dissection. And you said that bipolar is a very important tool for midbrain tumors. This is what you said. Now, I want to ask you, how many of these tumors are vascular to the extent that you have to use bipolar?
No. I use bipolar for dissection mostly. Coagulation. During removal of tumor, I do not coagulate anything generally. I just remove the tumor with the CUSA or suction. Don't coagulate. When you remove the tumor, that bleeding is generally gone. So at the end of surgery, maybe you can just use bipolar coagulation a little, but during removal of tumor, coagulation is very dangerous. This is general philosophy.
Yes, I agree with you, but that is why I was a little surprised that you were dissecting with bipolar. You had bipolar in your hand. So that was a little bit unusual for me to have bipolar in the brainstem.
But I use bipolar for the dissection mostly, yeah.
So why don't you use a dissector? Why don't you use a regular bayonet? It will be less heavy in your hand.
Bipolar, like my fingers. Suction also. Suction is not for only sucking. Suction is instrument also. This is what I learned from Professor Yashargil. Bipolar and suction, they are my fingers. So suction, mostly I use suction for a temporary retraction or just to feel the lesion or something. Not only for sucking,
Yeah, I agree with you. Completely agree with you, because many a times you remove the whole tumor and you have not coagulated even once.
Yeah.
You remove the tumor and the whole bleeding has stopped. So the coagulation is a tool which has to be used absolutely selectively, particularly in brainstem. If you take one normal vessel, you can damage very furiously. So do you agree with this?
I totally agree with you. Yeah.
Okay.
Yeah.
Okay, excuse me, gentlemen. We have to wrap it up. We have time for one more question. Radab, you have a question or comment?
Yeah, John Bennett. Hello, Dr. Ugur.
Hello.
This is Victor Hugo from Mexico City. It was really nice to see you in this amazing lecture, especially the last case that you showed us about the girl, 3 years old girl. It was really, really impressive. So, very simple question. How many hours do you need in anatomy dissection before doing a brainstem surgery?
I don't know. I mean, they don't need to spend 5 years, but I recommend young generation. They have to touch the brainstem. I am not very smart person, so I spent 5 years, but maybe 1 year is enough.
Okay, very good. Radab, you have a question? Last question?
Yes, Dr. John. Hello, professors. It's an honor to meet you again, and just a perfect webinar. And thank you, Professor Ogur, for the great presentations and tremendous work and shared cases. So my question in brief, Professor, in that case of the disappearing lesion in the left on the right, do you think that it was a lymphoma? And in that reason, do you think that sometimes we may take a biopsy just to take a biopsy and relieve the tumor if it was challenging or in very eloquent location? Thank you.
I mean, now the lymphoma, I have lymphoma cases that lymphoma, you can perform diagnosis with modern MRI and CT scan. Lymphoma is very typical lesion that in MRI and CT scan you can diagnose. And for lymphoma, you need biopsy still for treatment. But this case was not in MRI and CT, was not like a lymphoma. And the lymphoma cannot act like this, This case is very unique case. It doesn't fit anything. I mean, I know nothing. This is that I just would like to share with you. I am happy that I didn't touch it.
Okay, very good. Okay, Juha, you have any closing comments?
Thank you, everybody. It was a wonderful lecture. We all sent greetings to Yeditepe, especially to our great teacher, Professor Yasakil, and we thank Ugur for this excellent lecture. And next week we have Adul here again. What are you speaking, Adul? Next Friday?
I will, maybe I will give you the topic soon.
Okay. Then I thank everybody and thank especially Subin and Takashi for translating this.
Thank you.
Very hardworking.
Thank you.
How much audience
Thank
did
you,
it
Professor
have?
Toroya.
Thank you.
Did you see, Subin, how much audience?
Today it's around 1,000 audience. I think it's a lot for this. It's a rare midbrain glioma. It's a rare series, so it's.
It will increase during the weekend.
It's a very high-end topic.
Okay,
Thank you very much.
Okay. Thank you, everybody.
Yeah, we're glad you came, Ben. Thank you. We'll see you next week.
Okay. See you next week. Bye-bye.
See you next week. It's very interesting. Bye.
Thank you. Bye-bye.
Go ahead.
I want to ask Dr. Ture.
Okay, I'm sorry, I have to go. I'm sorry.